Today we are going to discuss the bladder cancer. Bladder cancer, the incidence is about 10 per 100,000. It is common in males and female. In bilharzia patient, the disease usually starts at earlier decades of life. It is common in white race. The types of bladder cancer, primary tumors and secondary tumors. The primary tumors, urothelial tumors, about 90%, which was previously called transitional cell carcinoma. Non-urothelial tumor like squamous cell carcinoma, adenocarcinoma, others like lymphoma, rhabdomyosarcoma, and pheochromocytoma. The secondary tumors, metastasis from melanoma, colon, prostate, lung, and breast. The pathogenesis or the risk factors, smoking is one of the commonest risk factors. Chronic cystitis increase the risk of squamous cell carcinoma. Chronic UTI also increase the risk of squamous cell carcinoma. Indwelling catheters also increase the risk of squamous cell carcinoma. Bilharziasis was one of the commonest disease which result in squamous cell carcinoma. Chronic bilharzial chronic bladder stones also result in squamous cell carcinoma. The chemical exposure of the carcinogen, the most important is aromatic amines and nitrosamine. Exposure to dye like aniline. Occupations that increase the risk of bladder cancers. Textile workers, dye workers, painters, laser worker, dry cleaner, and hair dye. Phenystein, it was used as analgesic. Chemical structure similar to aniline removed from the market. It results in renal cell carcinoma and bladder tumor. Radiation exposure to the bladder may result in bladder tumor. Cyclophosphamide also may result in bladder tumors. Smoking, tobacco smoking, one of the commonest risk factors which result in bladder tumor. The incidence of bladder tumor in a smoker is fourfold compared to non-smoker. The gross appearance of bladder tumor in bilharziasis, the most is nodular fungating tumor, papillary tumor, ulcerative tumor, and fibrillar tumor. In non-bilharzial patient, the commonest gross appearance is papillary, nodular, and ulcerative. This is the specimen show the presence of this is the nodular bladder tumor. This is the left ureteric orifice. This is the right ureteric orifice, and this is the prostate. And you see the bladder wall is very thick as a result either of chronic infection or bilharziasis. The microscopic appearance of bladder tumor in bilharzial patient, the incidence of squamous cell carcinoma about 50%, transitional carcinoma about 40 to 50%, adenocarcinoma about 2%. In non-bilharzial patient, transitional carcinoma from 90 to 80%, from 80 to 90%, squamous cell carcinoma from 5 to 10%, adenocarcinoma 2%. The squamous cell carcinoma, the origin of the squamous cell carcinoma is squamous metaplasia. Transitional carcinoma or urothelial carcinoma from the transitional epithelium lining the bladder mucosa. What are the origin of adenocarcinoma? Adenocarcinoma may result from nephrogenic adenoma, cystitis glandularis, which is one of the complications of bilharziasis, and the point of contact of the median umbilical ligament with the bladder is lined by columnar epithelium. The median umbilical ligament is the obliterated allantois or allantoenteric diverticulum. This is the transitional cell carcinoma or urothelial carcinoma grade 2. This is the muscle bundle, and this is the malignant cell. This is squamous cell carcinoma. This is the bundles of malignant cell. This, this is not the transitional carcinoma. This is a squamous cell carcinoma. This is squamous cell carcinoma. Sorry, this is adenocarcinoma. I'm sorry. This is adenocarcinoma, malignant gland. This is the malignant gland. The site of bladder tumor: posterior wall about 1/3, lateral wall about 1/3, anterior wall about 25%, vault about 5%, trigone about 5%. Metastasis: direct metastasis to the surround structures, lymphatic to the obturator, to the hypogastric, to the common iliac, to the parasacral, blood-borne metastasis to the liver, to the bone, to the chest, to the brain, to the liver, so on. Staging of bladder tumor. Staging of bladder tumor. It is called the TNM classification. It is very important to know the staging of bladder tumor. T for tumor, N for lymph node, and M for metastasis. The bladder tumor or the T staging is subdivided into two main categories: non-muscle invasive bladder tumor and muscle invasive bladder tumor. The non-muscle invasive bladder tumor is TIS, TA, and T1. TIS عبارة عن flat velvety area. This is mucosal changes. TA is papillary-like projection. Also, this is a malignant changes in the cell. T1 invasion of the lamina propria. يبقى TIS, TA, and T1. This is the non-muscle invasive bladder tumor. It was called previously superficial bladder tumor. In the three, TIS, TA, and T1, clinically, there is no palpable mass by digital rectal examination. The muscle invasive bladder tumor include T2 and T4. In T2, the invasion of the muscle layer, clinically mass, mobile with a smooth surface. T3, invasion of the lamina propria, invasion of the perivesical fat, invasion of the perivesical fat, clinically mass, mobile with irregular surface. T4, invasion of the surround structures, clinically hard fixed mass, hard fixed mass. Invasion of the prostate, of the seminal vesicle, of the lower ureter, of the vagina, of the uterus, of the cervix, of the ovaries. Invasion of the side wall of the pelvis, invasion of the pubic bone, invasion of lobes of intestine. All these are T4 bladder tumor. This is the picture of uh, transient carcinoma invading smooth muscle, or it is called urethelial carcinoma. Nodal metastasis. NX, the doubtful diagnosis. NO, there is no evidence of nodal metastasis. N1, N2, and N3. N1, single regional nodal metastasis in the true pelvis. That is, say, below the bifurcation of the common iliac artery. Multiple regional N2, multiple regional nodal metastasis in the true pelvis. N3, lymph node metastasis to the common iliac lymph node or above. N3 is considered distant metastasis. M staging. MX, doubtful diagnosis. MO, there is no evidence of metastasis. M1, distant metastasis, including nodal metastasis above the bifurcation of the aorta and above the bifurcation of the common iliac artery. What are the precancerous lesions? Squamous metaplasia result in squamous cell carcinoma. Leukoplakia result in squamous cell carcinoma. Leukoplakia is advanced form of squamous metaplasia. Nephrogenic adenoma and cystitis glandularis result in adenocarcinoma. Dysplasia أو atypia may result in urethelial carcinoma or transient carcinoma and carcinoma inside. It is not important for the undergraduate. This slide is not important for the undergraduate. Also, this is not important for the so the pathology of the bladder tumor entail incidence of bladder tumor, risk factors for the bladder tumor, gross appearance of bladder tumor, microscopic appearance of bladder tumor, metastasis of bladder tumor, and staging of bladder tumor, which is TNM staging or TNM classification. The second part of the lecture is the presentation of bladder tumor or diagnosis of bladder tumor. First presentation. Malignant cystitis, which include irritative bladder symptom, severe frequency, severe urgency, and up to incontinence. Hematuria, common in transient cell carcinoma. Necroturia, passage of necrotic tissue is common in squamous cell carcinoma. Symptom of metastasis to the liver, to the bone, to the chest. Examination, digital rectal examination or vaginal examination for verification of the stage of bladder tumor. Symptom of bladder tumor, the most important is malignant cystitis. Malignant cystitis means severe cystitis which not respond to the usual line of treatment. Investigation include lab investigation like serum creatinine, CBC, liver function, blood sugar. Urine cytology and the DNA cytometry is specific for urology. Serum creatinine, CBC, liver function, blood sugar can be done for any disease, but urine cytology and DNA for flow cytometry. Urine cytology, obtaining urine sample from the patient, centrifugation, staining, and examination under the microscope. If there is malignant cell in the urine specimen, the patient will be subjected to investigation like ultrasound, cystoscopy to exclude the presence of bladder tumor. Urine cytology is used for screening. The test is rapid, cheap, and can be done over a wide scale of population. DNA flow cytometry, this is the distribution of chromosome in the specimen. Either we obtain a part of the tumor and examination of this part for the distribution of chromosome. If the distribution of chromosome is diploid, like the normal cell, the prognosis of the patient will be more or less good. If the distribution of chromosome is triploid or tetraploid or pentaploid, the prognosis is fair prognosis and is not good. So DNA flow cytometry is used for follow-up of the patient and for research work and not for diagnosis. KUB, ultrasound and intravenous biography. KUB and ultrasound can be done, but intravenous biography is not performed nowadays. This is the KUB. This is a historical X-ray. There is a calcification in the wall of the blood. This is one of the complications of bilharziasis from deposition of calcium in the wall of the bladder and also fibrosis. This is a classic picture of ultrasound. The bladder must be full for detection of bladder tumor. Ultrasound is very cheap diagnostic tool, is very rapid, non-invasive, and can be done on the examining table. This is a historical X-ray. It was done before. This is piece of intravenous biography, which show the presence of irregular filling defect to the right side. The most important diagnostic tool in case of bladder tumor is cystoscopy examination under anesthesia and biopsy. Examination under anesthesia is then cystoscopy for visualization of the tumor and obtaining biopsy for histopathological examination and and DNA flow cytometry. Imaging to evaluate the upper tract, proper staging, and to detect if there is local or distant metastasis. CT and MRI are used for imaging of bladder tumor. MRI is more accurate in staging and detection of bladder tumor. Skeletal survey and bone scan are used for detection of metastasis in the bone. A skeletal survey is a plain X-ray from the head to the toes. It's very rapid, very cheap, and it can be done rapidly. On the other hand, the bone scan is a very expensive test which is done to detect the hot area in the bone. This test is very sensitive but not specific. Why the test is very sensitive? Because any hot area in the bone can be appear. But what are the differential diagnoses of hot area in the bone? The differential diagnosis of hot area in the bone is Baggett's disease, osteoarthritis, healing fractures, old trauma. All these are benign lesions. Then metastasis in the bone or primary bone tumor. So that bone scan is very sensitive test, but is more or less not specific. This is the CT of bladder. This is a large bladder tumor is in the anterior wall of bladder tumor, dumal bladder tumor. This is the CT. This is MRI, a bladder tumor, dumal bladder tumor. Also, this is a MRI, which reveal bladder mass to the right side. This MRI of the bladder, which show a large intravesical mass anteriorly and may invade the perivesical fat. This. So we finish the pathology of bladder tumor, the presentation of bladder tumor, and investigation of bladder tumor. كل المحاضرة دي كانت لسنة 7. بعد كده في تريتمنت محاضرة لوحدها بعد كده. But for the Manchester treatment of superficial bladder tumor, this is the second part of the lecture is for Manchester. Treatment of superficial bladder tumor or non-muscle invasive bladder tumor, non-muscle invasive carcinoma. TE and T1, TURBT, transurethral resection of bladder tumor, intravesical BCG or chemotherapy can be given according to a special protocol. The patient of TE and T1 must be followed up by urine cytology and cystoscopy according to a specific protocol for TE and T1 bladder tumor. This is the cystoscopy of the bladder tumor. This is the large bladder tumor. This is the resection of transurethral resection of the bladder. The TIS, this is lesion become invasive in about 50% of cases. The treatment of carcinoma in situ or tumor in situ is intravesical installation of BCG and regular follow-up cystoscopy and cytology according to a specific protocol. Cystectomy is indicated when the muscle invasion is evident or the or failure of intravesical immunotherapy, or there is severe complication and side effect of intravesical installation of procedure. يبقى cystectomy is indicated in case of TIS. First, failure of treatment in the form of muscle invasion. Second is major side effect of intravesical decision. The treatment of muscle invasive bladder tumor T2 and T3, the most important method or curative method of T2 and T3 is radical cystectomy and urinary diversion with the 5-year survival exceeding 50%. Radiotherapy and chemotherapy can be given in patients with T2 and T3 bladder tumor in case of unfit patient for surgery or the patient refused surgery. So the result of chemotherapy and radiotherapy are unsatisfactory. T4 bladder tumor and metastatic disease, the treatment is palliative or symptomatic treatment. Radiotherapy can be given for repeated cases of hematuria. Chemotherapy can be given. Surgery can be indicated in the form of palliative cystectomy in case of intractable bleeding. If there is severe bleeding not respond to any measure of treatment, palliative cystectomy can be done for this patient. Radical cystectomy is the standard treatment of T2 and T3 bladder tumor. It includes excision of the pelvic lymph node and the wide excision of the bladder, perineal covering, perivesical fat, pedicles, ligament, and lower urethra. In male, vas deferens, seminal vesicle, and the prostate must be excised. In female, fallopian tube, uterus, upper vagina, ovaries, both ovaries in postmenopausal female. In premenopausal female, we can remove only one ovary. The method of radical cystectomy, either open surgery or laparoscopic or robotic surgery. The mortality rate of radical cystectomy is about 1%. The morbidity from 20 to 30% in the form of hematuria, bleeding, rectal injury, deep vein thrombosis, pulmonary embolism, pelvic abscess and infection, small bowel obstruction. After radical cystectomy, we have two ureters. So, both ureters draining urine from both kidneys. So, we divert urine. Either non-continent method and continent method. Non-continent method like ileal loop conduit. Continent method orthotopic diversion, ileal W bladder, cutaneous ileocecal pouch, or rectal diversion or intestinal diversion. Non-continent urinary diversion is called this is the ileal loop conduit. This is the kidney, left kidney, right ureter, left ureter. We isolate a loop from the distal ileum, about 15 centimeter in length. We close the inner end and anastomose both ureter to the lobe. This is the left ureter, this is the right ureter, and the other end of the lobe is open on the skin. This is the feature after the finishing the operation. This is the open end of the lobe, open to the skin, and urine is collected a plastic bag. In this bag, this is appliance for collection of urine. The patient is incontinent for urine, and the urine is collected in a plastic bag. Non-continent urinary diversion indicated in high-risk patients like renal and hepatic impairment, and isolated vascular lobe of the ileum is isolated, ureters anastomosed to the lobe, and the urine is collected in a plastic bag. Ileal lobe conduit. The types are ileal lobe conduit, ureterocutaneous anastomosis, colon conduit. In case of bilateral ureterocutaneous anastomosis, this is indicated in high-risk patients. The right ureter anastomosed to the skin, and the left ureter is anastomosed to the skin, and the urine collected in two bags. This is case, or this is type of diversion indicated in high-risk patient. Continent urinary diversion, orthotopic diversion. This obtaining about 40 centimeter from the distal ileum, like this, and this 45 centimeter is used for the new bladder, for the configuration of the isolated segment from the ileum. This new bladder obtained the two ureter and anastomosed to the membranous urethra. Orthotopic new bladder, the procedure of choice, indicated in fit patient with adequate renal and hepatic function. The urethra is maintained continent using the continence in this case depend on the external urethral sphincter. An ileal segment about 40 centimeter is isolated and reconfigured as a sphere, anastomosed to the membranous urethra, and both ureters are anastomosed to this new bladder. W bladder, this is Mansoura pouch or Abu Lu'ayn pouch, the urethral cock and Studer pouch. All these are types of orthotopic diversion. The second type of orthotopic diversion or continent diversion is the both ureters are anastomosed to the sigmoid colon. Ureterosigmoidos and its ureters are anastomosed to the sigmoid colon with anti-reflux technique. Anal sphincter is the continent mechanism. Urine and stool are mixed with each other, leading to the highest incidence of complication. Continent cutaneous diversion. The distal ileum is used for configuration of a bladder, and this bladder is anastomosed to the skin, and there is a valve is configured to prevent leakage of urine, and the patient evacuates this bladder by a plastic catheter every 3 to 4 hours. Continent cutaneous diversion. A continent mechanism as the ileocecal valve is anastomosed to the skin as a stoma. يبقى the ileocecal valve is used as to prevent leakage of urine. Emptying of urine is achieved by self-castration. What are the complications of urinary diversion? Hyperchloremic acidosis. It is seen when the ileum or colon are used. Urea is digested by bacteria and converted to ammonia. Ammonium chloride absorption leading to hyperchloremic acidosis. In contrast, the use of gastric segment, using gastric segment as urinary diversion lead to hyperchloremic alkalosis, more common in patients with renal damage. Symptoms of hyperchloremic acidosis include thirst, anorexia, nausea, vomiting, weight loss, weakness, and confusion and coma. Chronic acidosis lead to bone demineralization. Treatment: fixation of catheter, intravenous infusion of alkaline agent like sodium bicarb, antibiotic, ureterosigmoidostomy should be avoided. The hyperchloremic acidosis is common in case of ureterosigmoidostomy or anastomosis of the ureter to the colon. Complication also on urinary obstruction, infection, stone formation, and renal failure. Nutrition deficit and malabsorption as a result of using the distal part of ileum, which is responsible for absorption of most vitamin and mineral. Adenocarcinoma of the colon because of long contact of urine with the colon. Stomal problem in the form of prolapse or obstruction or stenosis of the stoma. Thank you very much.